Okay, and just like that, it looks like it's at 3 o'clock by our watches here. So we're going to go ahead and get started with our monthly Catch webinar. This one's the MD Anderson and Catch Partnership to Advance Youth Cancer Prevention, and we're delighted to have our guest, Dr. Ernest Hawk, here from MD Anderson. My name is Brooks Ballard, and I'm with the Michael and Susan Dell Center for Healthy Living at the UT School of Public Health. And I'm just going to do a little housekeeping here before we get started. So first of all, I wanted to let everyone know that this webinar is being recorded and will be archived. It'll be up on the catchusa.org website at the end of this week. You can also find it on our MSD Center's YouTube page. We will also be sure to send out a link to everyone who registered for the webinar, so you don't even have to worry about looking for it. We'll send it right to you. For today's webinar, we encourage you to ask questions throughout the webinar by typing them into your questions box. But to keep us on track, we're going to hold off on answering those until the Q&A portion of the webinar at the end of Dr. Hawk's presentation. With that being said, I'm going to go ahead and hand it over to the Executive Director of the Catch Global Foundation, Duncan Van Dusen. Duncan?
Super. Thank you, Brooks, and thank you, everybody, for joining the webinar today. Before I introduce Dr. Hawk, let me just also thank the Michael and Susan Dell Center and the School of Public Health for hosting these webinars. So as you may know, the Michael and Susan Dell Center is an international leader in conducting research and providing programs to promote healthy living for children, families, and communities. And their work fosters improved health behaviors among youth, influences policy and environmental change to support healthy living, and advances professional education and community service. So given their mission and given the mission of Catch Global Foundation, really was a perfect partnership with MD Anderson, and I think is a perfect speaker for our webinar today to have Dr. Hawk. Ernest Hawk, MD, MPH, is Vice President and Division Head for Cancer Prevention and Population Sciences at the University of Texas MD Anderson Cancer Center. He holds the Boone Pickens Distinguished Chair for Early Prevention of Cancer. And his additional responsibilities include leadership of the Duncan Family Institute for Cancer Prevention and Risk Assessment, and co-leadership of MD Anderson's Cancer Prevention and Control platform, which advances community health promotion and cancer control through evidence-based public policy, public and professional education, and community-based service implementation and dissemination. Dr. Hawk has published more than 175 scientific articles and book chapters, edited 3 books, and serves as a senior deputy editor for cancer prevention research. He's also on the editorial board of Cancer Medicine. And I'd just like to add on a personal note, Dr. Hawk is also an extremely nice guy and a real pleasure to work with. So thank you very, very much, Dr. Hawk, for joining us today, and we'll pass it over to you right now.
Thanks. I'm really glad to be with you and to be with the Catch Global Foundation in partnership to advance youth cancer prevention. What I'd like to do this afternoon is introduce you a little bit to our institution here, the University of Texas MD Anderson Cancer Center, talk about the opportunity that we have to promote cancer prevention and control, both at a clinical level but also at a population level, and share a little bit with you about the cancer control initiative of the institution. It's really a reinvigoration of a commitment to making cancer history on the population level. And then finally, we'll talk a little bit about how we're planning to work together with the Catch Global Foundation to advance youth health promotion and cancer prevention. So to begin with, the slide that you have before you is a picture of the Duncan building here on our campus. We have an entire building devoted to cancer prevention and control. The second floor of this institution, of this building, focuses on cancer prevention specifically. Next slide. So to begin, MD Anderson has a mission of eliminating cancer, as we state, in Texas, the nation, and the world. And we do so by operating in 4 spheres of activity. First and foremost, research is the foundation of everything we do, asking and answering questions of relevance to the needs of patients that make their way to our institution as well as the broader population. It lies at the core of everything we're about. But then we describe our work as being translated in 3 directions. First of all, to individuals who, again, make their way to our institution through the clinical care we provide. We see now, on average, about 40,000 individuals a year in our Clinical Cancer Prevention Center, where we provide kind of state-of-the-art in risk assessment as well as preventive and screening services. So anything that's evidence-based, oriented around the individual, we offer to try to prevent the development of cancer. Secondly, the translational effort of our research is to future generations through the education, training, and mentorship programs we have in place. Those are relevant across the spectrum of cancer needs, but in our division we concentrate, of course, on prevention and control. And at any one time we have anywhere between 150 to 200 individual trainees working toward their terminal degrees, as well as postdoctoral training, for example, oriented around cancer prevention and control. And then the third area, translational area of our research activities, is to the broader community, folks who hopefully will never make their way into the institution as a cancer patient. And so this is an area that the institution is committed to for the 70 years of our existence, but I would say it's particularly energized under the directorship of Dr. Ron DePino, our current president, who really is elevating our commitment and our activities in community-based cancer control. And then the pink arrows depict the fact that ultimately what we hope to generate across our institution is research that informs clinical care, education, and cancer control, but then also that dissemination activity informs the research questions we ask and answer. All of this was, and in particular those translational directions, were further highlighted and energized under the Moonshot program that Dr. DePino established on our campus in 2012, really intending to accelerate translational progress and bidirectional communication across those 4 domains of activity. Next slide. So the great promise of cancer prevention and control is highlighted in this slide, and I'll walk you through it. So first of all, it's estimated, based upon best available estimates, that 1/3 to 1/2 of all cancer deaths that occur in Western populations, such as the United States, are actually preventable. If only we could educate the public and better disseminate evidence-based programs at the personal and population level. And so that's really what our institution is devoted to. So in the purple is laid out the variety of strategies by which personal actions can be taken. This is many times in a clinical context, but it may very well be in a family context as well. And so there are 7 spheres of action that are important, and taking them 1 through 7. First of all, knowing your own family risk, the risk that you were born with, as well as those that have amassed across your lifespan through a careful clinic-based assessment is the beginning place. So this distinguishes you from the general population. What are your particular risks based upon both your lifestyle choices that have compiled across the span of your life, as well as the things that you were born with. Secondly, then, taking action at a personal level to eliminate or limit tobacco exposure, both direct as well as indirect, secondhand exposure, for example, from other family members. Third, eating and maintaining a healthy diet, again, not only at one point in time, but across your lifespan. Fourth, getting sufficient levels of physical activity, or for most of us, that would mean increasing physical activity. Next is reducing or limiting harmful UV exposure, sunlight, artificial tanning salons, that sort of thing, and we know increases the risk for cancer, which is actually the most common skin cancer, which is the most common type of cancer in our population. Next, following evidence-based screening programs, and right now we have evidence to suggest reductions in cancer mortality associated with colon cancer screening, breast cancer screening for women, cervical cancer screening in women, as well as the newest evidence-based screening recommendations for lung cancer in high-risk individuals by spiral CT exams done on an annual basis. And then finally in that list is the use of preventive medicines and vaccines. So we already have effective vaccines for several types of cancer. 2 that come immediately to mind: hepatitis B for liver cancer, and HPV, or human papillomavirus, vaccinations that can protect established against cervical cancer, anal cancer, and some types of genitourinary cancers, and may very well reduce the incidence and mortality of head and neck cancers as well, an issue that's yet to be proven and end up in those product labels. But that outlines 7 sorts of spheres of action around which cancer risk can be reduced by personal action. And then complementing those personal actions are evidence-based actions that can be taken at a population level. And these largely fall into 3 spheres of activity: public policy, second, delivery of community-based proven clinical services, so ways to enhance the delivery of those, whether they're on a one-on-one practitioner, patient level, or more broadly in the community. And then third is cancer prevention through education on both the public as well as the professional level. And that's really the focus of this relationship: improved public education that hopefully will drive personal actions as well as population level actions. Next. So in all of that work, an emphasis on early habits and youth is critical to success, because many cancer risk behaviors are developed very early in life and carried over into adulthood, or with long-term impacts that aren't seen until adulthood. A couple of examples: we know that more than 80% of adult smokers actually began their addiction to nicotine as youth, typically between the ages of 13 to 18. And in addition, evidence now showing that one blistering sunburn in childhood or adolescence more than doubles the risk of melanoma, the most critical type of skin cancer, not the most frequent, but the most often fatal type of skin cancer that occurs not until later life. So understanding cancer risk and setting patterns early in life through both individual interactions with children, youth, as well as in a family context are really important toward that long-term goal of reducing cancer risk. Next. So that leads us then to the MD Anderson partnership with the Catch Global Foundation. The intention behind this relationship is to improve the effectiveness of both entities in living up to their mission of reducing long-term risks of cancer as well as other chronic diseases, which lies at the core of both of these institutions. Next slide. So let me speak a little bit to the MD Anderson side of that equation. I mentioned earlier that our institution has commitment to cancer prevention, effective cancer prevention at the population level, and we describe that as our work in cancer control. And so at the top of this slide is depicted our mission statement, or our definition of cancer control. And it is to develop, but more importantly to deliver, comprehensive, evidence-based strategies in cancer prevention, screening, early detection, and survivorship to achieve a measurable and lasting reduction in the cancer burden of our population, especially among the underserved. Let me unpack a few of those concepts. So first of all, when we're speaking of control, we're talking about comprehensive strategies that involve a full array of actions in policy, education, and service delivery. Next, they're distinctive from a good idea that you might have had over a recent conversation with peers or with your spouse over dinner last evening. These are not just bright ideas that you might have arisen through those sorts of conversations, but rather evidence-based things that have been proven to be effective in at least one community to address one cancer risk factor using one strategy. So they're distinctive from bright ideas to things that have gone through the challenge of research and been evaluated by peers as something that is reasonably certain to reduce cancer risks. So they have an evidence-based component. Next, the goal is to achieve both measurable but also lasting reductions in cancer burden. Many times we do things that are good, but aren't necessarily measurable. Here we're trying to identify things that have that sort of measurable and lasting long-term impact. And then finally, the last part of this statement focuses not on just the general population, but going where the cancer burden and cancer risk factors tend to concentrate, and that's in those who are, quote, underserved, who are typically less well-educated, less resource blessed. Many times this concentrates in the more disaffected members of the community. So concentrating particularly where the need is the greatest. And we've defined cancer control relatively specifically and at a fairly high level. We did this intentionally. At MD Anderson, we have some 20,000 employees. When I came here 7 years ago, we would use the term cancer control. Many times it confused people as much as enlightened people. And so what we did is oversimplify essentially the definition. It is something that was memorable, PES, which spells pest, which is Latin for feet. This is the work of the institution out into the community, the feet of the institution into the community. So outside the walls of our institution per se. And the PES stands as an acronym, the P standing for policies, which may be implemented at any level of socio-political organization. This suggests perhaps worksite or schools or government organizations to take action at those levels that typically have a broad and lasting impact. The E stands for education. That goes in either of two directions. Toward the general public, raising their awareness through things like school-based programs or media campaigns or counter-marketing programs to raise awareness, but then also motivate action on behalf of population or a professional serving that population. So this also includes things that would improve the knowledge of health professionals, particularly those outside of our own institution, through a variety of continuing medical education programs or, in some regards, telementoring activities so that we can improve the ability of local practitioners to better serve their communities through evidence-based strategies. And the S stands for services. Here we're speaking largely of clinical services, but services that are not delivered in our own clinics, but attempt to help local providers in the delivery of evidence-based services in their context. So this might include things oriented towards community-based screening, early detection, health counseling around healthy nutrition or physical activity, or immunization programs, preventive services delivered, again, outside of our own clinics, but in helping providers deliver these in their own contexts. Next. So that's what we're talking about when we're talking about control activities, public policies, education, and services. I mentioned the critical need for all of these actions to have an evidence base. And so what we do is rely upon published literature and particularly its compilation by authoritative bodies. So in the middle of the slide, for example, the Guide to Community Preventive Services put out by the CDC and updated on a periodic basis provides a roster of the evidence-based actions that one might take in these areas of public policy, education, service delivery. Similarly, at the bottom of the slide, the NCI puts out a database that they term the Cancer Control Planet or the RTIPS database, where again, the evidence-based programs that have been shown to be effective, measured, and impactful are compiled into a roster of programs that can be recommended. Similarly, at the top right of the screen, we see the World Cancer Research Fund and the American Institute of Cancer Research do similar sorts of evidence-based literature assessments and compilations and publish them on a periodic basis, particularly those relevant to nutrition and physical activity. And in the bottom right, another authoritative reference here focused on Texas, the Texas Cancer Plan, which many of our faculty and no doubt those from the School of Public Health and other agencies across the state contribute to on a periodic basis. Down in the bottom left, I've highlighted the JEM Internal Medicine article. This is a recent study that we did in the domain of community-based services where we have evaluated a new strategy to more productively connect smokers to services that are widely available, in this case the Texas Quit Line. And by doing a study using the usual Ask, Advise, Refer individual practitioner referral-based system, we compared that to a means by which we would connect smokers through the electronic medical record at our own institution as well as others in which we studied. And we found that we were able to boost referral rates by more than tenfold by using the EMR as opposed to busy practitioners to make that referral. But there again, before implementing that, we published that, we put it through the crucible of peer review, and now it's referenced in resources such as those depicted on the right-hand side of this slide. So it's one way that we're attempting to connect our research out to activities in public policy education and service delivery to facilitate better delivery of these messages and programs out to the broad public. Next slide. So this is a busy slide, and I apologize. Usually I animate it, but let me walk you through it. And what it's pointing out is that any time that we undertake an endeavor in cancer control, it becomes a relatively complicated business quite quickly. Depicted in the yellow there horizontally, we see what I've just outlined, the way MD Anderson at least describes its actions in cancer control, from relatively passive actions on the left-hand side of the screen, something like public education, where you're raising awareness, raising understanding, out to those that probably have the longest lasting and broadest impact, something like the implementation of a public policy or its enforcement. So that's one domain in which we need to think carefully about the programs we put in place. Around the blue is another dimension that's important to consider, whether a program we would put in place would have a very focal effort, for example, raising HPV vaccination, addressing cancer-causing infections, out to addressing issues of UV exposure, or connecting people to evidence-based screening strategies. So that orientation along dominant risk factors is another very important issue to consider in cancer control. In pink, then, are depicted the levels of opportunity for interventions to be applied. And they can extend from an individual out to something like the family unit, broader aspects of community depicted at the regional, state, national, or even global level. So another very important dimension to consider when designing, implementing control programs. Depicted in green is how we might tailor more specifically based upon group risk where a program should be implemented. And that issue of risk assessment that can occur within, example, considering levels of family or geopolitical organization, where to target. And that could be based upon the level of cancer risk, education levels, socioeconomic levels, a whole variety of ways to try to think about tailoring a program and toward the population whom you hope to intervene and hope to have an impact. And then finally, in orange, up in the left-hand corner, I've outlined that at least at Anderson, we're also thinking about how to deliver these programs based upon the targets that we've placed for ourselves in the moonshot effort. And so there we have some 6 to now, I think, 13 different organ systems around which we've designed programs. And some of those are relevant here. For example, through public education, we can have a very profound impact against HPV-related cancers by more effectively connecting folks to evidence-based screening programs as well as the HPV vaccination efforts, just as one example. So it becomes a rather complicated issue anytime you're attempting to implement a cancer control program. Next slide. So how do we do that? Well, we rely upon our own expertise, but importantly depicted here is we rely upon a variety of partners, and they occur in many different domains. So in the top left, for example, a number of different government agencies and NGOs that we've engaged with to try to make sure that our proposals are well aligned with their attention, so we're not creating redundant programs or conflicting programs. In the bottom left, we've also taken our ideas and our programs forward for consideration by internal bodies here, such as our Board of Visitors. We have now a component of that provides advice to the institution specifically in cancer control. We also rely upon a variety of different community advisory groups, and we've summarized a couple of those here under that heading. In the top right, we've also looked for corporate partners, and so many of our control efforts are extending outside of our institution, not only with our own faculty and their relationships, but with a variety of corporate partners. Perhaps the most mature example on this roster is with Jason's Deli. We began an association with them with a philanthropic intent, and they were very interested in donating to MD Anderson. We thought, what a wonderful way to work together by perhaps receiving back some monetary portion of a sale, and so we partnered around the sale of water. And so if you buy a bottle of water at Jason's Deli, a dime of that comes back to our institution's research mission, just as a way of supporting MD Anderson in its attempt to serve the population. Jason's was very excited about that. We were very excited about that. But then over time, it became apparent that they would like to raise the healthfulness of their menu. And so they engaged our nutritionists to visit their corporate enterprise, to provide advice on what a healthy salad might look like. And now there actually have been 2 salads offerings in their corporate establishments that have been co-developed with MD Anderson nutritionists. So with careful attention to both the products, the ingredients, as well as the caloric offerings and the nutritional assessment of those offerings. So an entirely different way of working with what began as a philanthropic relationship, but molded over time to not only be that philanthropic investiture at the beginning, but now a way to work together to try to improve the healthy nutritional offerings to Jason's Deli clients. And there are many other examples there. I'll move down then to the bottom right. We've also invited a number of academic advisors from other institutions across the country that have a particular investment in cancer control and prevention to come in and provide advice around what we're doing. Every one of them have endorsed this direction of their institution, and specifically the Catch relationship that we've forged with our Catch Global Foundation partner. Next slide. This is pointing out to how we've organized ourselves. So at the inception of our cancer prevention and control enterprise, we thought that most of this would be led and developed by faculty, but we soon realized that here we're talking not only about research questions, but also those actions in public policy education and service delivery, which our faculty many times have expertise in, but aren't really the people, the boots on the ground, the people in the trenches. And so what we did, depicted in the blue here, is to take various components of the MD Anderson enterprise. These are, in the boxes, really individual offices that were doing great work historically in various actions that we might term cancer control, but in some cases weren't as communicative with their peers. And so what we did is forge a leadership team that meets on a weekly basis to discuss various programs that we have in place and how we might work together more productively going forward. This draws upon the expertise of our health policy group, our government relations group, our professional education, community relations and education group, as well as the scientists interested in prevention and control, led by or represented by myself and Dr. Wetter. And most recent addition to this has been our own human resources group, because we realize that we need to change our own local environment and the health offerings to our own employees, just as we develop programs for those outside our institution. So this is the team of leaders that are involved in this effort in cancer control here at MD Anderson. We're supported by platform operation with some existing colleagues, as well as now additional components that we're hoping to add in the near future, represented in the pink. And so there what we're doing is creating position descriptions in some cases, in other cases forging partnerships, just as we have with Catch Global Foundation to bring in additional expertise that we're currently lacking. That falls in the domains of dissemination and implementation, youth prevention and education. Thus you see why the Catch Global Foundation is such a critical partner for us, community health advocates, public health partners, as well as public health practitioners. So a whole variety of folks who live and breathe this issue of making change in public policy education and community-based service delivery. Next slide. So those are the folks who do the work. Now, what work do they do? Well, this outlines that rather, again, than putting forward programs that we might have discussed over informal conversations with peers or spouses the night before, what we've done is try to put together a process by which we consider action. So up in the top left, that's a man holding a light bulb. So there's the bright idea that might come to us. The first thing we do when someone proposes it is put it through a assessment and an evidence appraisal. How does that idea weigh against impactful actions that are known based upon prior research? If indeed there's good alignment, then we will develop a product concept, make a critical go-no decision based largely on relationships and funding and resources available, put a prototype product together, and then put that into implementation, development, scale-up if successful, followed then by maintenance and dissemination. Really, this is depicted at the end that there will be an evaluation, but actually that evaluation process is kind of ongoing at each of the critical junctures. There are steps in the process. But this is intended to just point out that, again, there is a structured, milestone-driven process that we have in place for action here, because, of course, the action is resource-intensive and important and intended to achieve a goal. So around each of those steps, there is an evaluation component that's embedded. We've also thought carefully about how we prioritize the actions that we take, because, of course, in this space with great public need, there are many opportunities to create long lists of things that we might do. So what we try to do is prioritize those that are, first of all, strongly related to our moonshot effort, because that's really the funding base for much of the inception of these programs, at least. Secondly, that there's a careful consideration of resources, expertise, and our capacity. Third, that there's the potential for a population-level impact that's measurable and hopefully sustainable across time. Next, we're looking for programs that are particularly of benefit to the underserved and disproportionately impacted portions of our community. And finally, we think it's important to target children and adolescents in particular, because healthy lifestyles and the adoption of healthy approaches to cancer control are founded early in life and carried across the lifespan. So we think that notion of children and adolescents is really important, which again underlies the whole relationship and the prioritization of the relationship with the Catch Global Foundation from MD Anderson's perspective. Next slide. So that relationship is the point really of today's webinar. What we've done is sign a 4-year agreement with the Catch Global Foundation that brings additional resources to bear, particularly to develop a more robust infrastructure and operations of the Catch Global Foundation, and importantly, the forged partnership. Secondly, we've committed ourselves to extending curriculum development as well as then disseminating evidence-based curriculum once it's been established. And then third, those funds go to support the program delivery as well as technology support. The anticipated projects coming out of this partnership are both developing and disseminating new program content, and that's oriented in particular around the areas of MD Anderson expertise that might be of use to the Catch Global Foundation and its mission. So in particular, new areas around UV protection and tobacco use prevention. We also hope to partner with CATS to transform the current curriculum into a digital format so that it's more accessible and disseminable out to the broader public that we hope to reach. Next slide. So if we take a survey of the CATCH program as it exists now, it's extremely strong in promoting healthy physical activity and nutrition oriented from preschool through elementary, middle schools, as well as after-school programs. MD Anderson programs already exist, in particular the Aspire program, which is oriented around tobacco use prevention, that currently has been developed and disseminated to some level, at least in middle, high school, and as an after-school program. Another program that we have in place around UV protection, oriented particularly around preschool and youth, is a program that we've termed Ray and the Sun Beatables. We're hoping to extend that out further into higher grades beyond preschool program, as well as taking the Aspire program and developing a program that's relevant for younger kids a bit earlier. And then the other program we hope to develop is around HPV vaccination. This is probably best targeting middle and high school age groups because of the sensitive nature involved. Nevertheless, represents a huge opportunity, estimated to be as high as 70 to 90% reductions possible through better vaccine dissemination. So this is a little bit about where the CATCH program is today and where this partnership might take it going forward. Next slide. In terms of content. So a few words around the tobacco use content that MD Anderson currently has, and which we hope to develop further and tailor for incorporation into the CATCH family. Next slide. So I mentioned that we have a successful program that's nicknamed Aspire, that stands for a Smoking Prevention Interactive Experience. This program was developed by Alex Prokhorov and his colleagues. Working, I believe Steve Kelder was even involved in the early days of its development. It started in 2000 as a research project oriented around tobacco prevention and cessation, targeting high school youth. It is now internet-based with various program components, including a whole variety of video games, quizzes, flash animation, so that hopefully it's speaking the language of youth as well as providing content useful to you. We've proven that it's not only useful in its current form with school-based dissemination that's reached some 12,000 kids, 4,500 or so who have actually completed the entire program. It's been disseminated out to 24 states, one international location, and with ongoing activities to disseminate the program beyond the current base. Along those lines, we've learned that it can be and should be culturally and linguistically tailored for specific audiences, so we have some expertise in that as well. To date, the website, now moving from a school-based dissemination out to a web-based dissemination, has averaged some 800 visitors per month, reaching some 40,000 visitors from at least 66 countries. So you can see there again we're learning how to scale up and disseminate more broadly using the internet. And a Spanish version was launched in 2011. We're in the middle of further tailoring that towards Mexican and Colombian audiences right now. Next slide. A bit around, I mentioned the importance of the evidence base. So indeed, Aspire is now a research-tested intervention program that is included in the NCI database. It's given its ratings anywhere from 3 to 5 based upon its research integrity, the impact of the intervention, as well as its ability to be disseminated. You can see their estimates around reach, effectiveness, adoption, and implementation. So a lot more is still to be done around implementation. And we've just taken one slide out of the evidence that has been generated earlier and published in 2008 in Nicotine and Tobacco Research, where we show smoking initiation rates among non-smoking 10th grade students over an 18-month follow-up period. And you can see the intervention, Aspire in blue, with 1.9% of students initiating tobacco during that interval, as opposed to the comparator of education materials alone, almost 6% of kids unfortunately starting smoking over that interval. So a very effective program, about a 60% reduction over an 18-month period of follow-up in those engaged in the program versus not. Next slide. And some of the feedback that has been that's been compiled around Aspire. I apologize for the misstated title there. With the vast majority of students stating that they had learned new facts, they were influenced not to use tobacco, a really important metric, that they better understand tobacco facts, and would recommend Aspire to peers. Next slide. So that's a little bit about the tobacco expertise that we have in place, relevant to hopefully parts of at least a catch audience. Next, I'll review just a little bit around the sun protection content. Here we've had, next slide, a couple of investigators particularly interested in this issue, Ellen Gritz as well as Mary Tripp, have developed a variety of different programs, and the one that we're promoting here is called Ray and the Sunbeatables. I apologize again for the jumbled context there at the top. But what this is a sun safety curriculum oriented towards preschool audiences. The purpose is captured there to teach children about sun protection and promote those behaviors at a very early age. And the theme of this program is that Ray and the Sunbeatables are superheroes, and each of them have been endowed with a unique superpower to help protect kids against harmful UV exposure. That includes things like access to sun clothing, sun protective clothing, hats, sunglasses, sunscreen, sunshade, and knowing when it's safe to be outside. So those are the superpowers that are embedded within these superheroes. It's a way that kids can relate to the importance of these various variables in protecting them from the harmful effects of UV radiation. Next slide. And one example of a curriculum activity is a simple issue of going outside and teaching kids how to measure their shadows, with long shadows being present in early morning and late afternoon, indicating when it's safer to be outside as opposed to midday when shadows are very short, being the most harmful or potentially harmful time to be exposed to the damaging effects of sunlight. Next slide. And the program has been developed and shown to be effective. An early form of this sort of content was in the Sun Protection is Fun program, which has been developed, implemented, and tested with beneficial effects at two levels, both in terms of teachers becoming more knowledgeable about the importance of sun safety and more confident in delivering that sort of content and those messages to children, as well as improved behavioral effects on the teacher's use, for example, of sunscreen, protective clothing, and recommendations regarding shade to children. Similarly, the program had a parental orientation to it, and once again, parents were demonstrated to be more knowledgeable about sun protection and actually practicing what they had learned, improving their sun protective behaviors oriented towards their children, captured in those two references. Next slide. So those are some of the programs that we're hoping to bring to the CATCH Global Foundation and do the CATCH program for incorporation. We're hoping now in the future to develop additional materials around HPV vaccination, as I outlined earlier, particularly for older kids, as well as a program helping kids understand the importance of science and the way it leads to healthy behaviors, or a way it should inform healthy behaviors. This again would probably be something for kids at more advanced levels, but we find it to be somewhat perplexing that every time a study is published in the lay press, they're all viewed as though they're of similar quality and similar impact. And we think this is a critical need for our population to better understand science, the scientific process, and how to evaluate science when it's published so that there's a better understanding of the difference, for example, between a pooled analysis of 20 randomized controlled trials versus a case series or a preclinical study that may have been done in human tissues or even animal models of human disease. Right now, the lay press many times publishes those sorts of results as though all of them are important and impactful and should impact human behavior, when in reality they're very different. A green tea study done in rats showing reductions in mammary cancer, for example, is very different than a large randomized controlled trial of a cancer preventive agent tested in 18,000 women. And however, many times they're reported in much the same way. So we think there's a real opportunity to raise the understanding of science and scientific process, beginning with kids, but of course relevant to their parents and the broader public as well. Next slide. So another important aspect of our relationship is in dissemination. And next slide. So first of all, to permit dissemination, we need translation, and that is of the current programmatic content into a more digital and accessible format to really fuel the efforts in dissemination that I think both the Catch Global Foundation and MD Anderson see as the potential of the current Catch program. And secondly, the opportunity to translate its messages across languages and across cultures. Because everywhere we go, we see a need for more education like Catch has developed, and a real opportunity exists there. Next slide. So what we hope to do after the translational efforts is then use MD Anderson's name and its relationships to assist in disseminating Catch both nationally as well as internationally. And this defines a variety of different institutional relationships that we have. Of course, we're based here in Houston. We have 5 or 6 regional partners here in the greater Houston metro area. But we also have a variety of other affiliates, both named partner institutions in Phoenix as well as Camden, New Jersey, a whole variety of other relationships through our certified member organizations. While none of these would say today that cancer control is a important part of their work, all of them aspire to have cancer control as a part of the services that they provide. And so this is one way that we hope to take the Catch materials and assist in their dissemination at a national level. This is just one example. We're hoping to build many other examples through corporate relationships as well as a variety of other relationships that we're establishing now. Next slide. And similarly, we think the Catch program, as I alluded to, has the potential to reach international audiences as well. I know there's already been an effort in that regard. We have a sister institution relationship where we forged strong relationships with some 29 institutions globally, and we're hoping, many of those already involve efforts in prevention, control, and education. In almost every instance, we see populations outside of that of Houston where the same sort of information that Catch specializes in would be of use to other populations. And so we've already begun making our sister institutions aware of the Catch program, and we're hoping to be able to work with our partners to further disseminate Catch and its incredible impact far beyond our own institution, our own country, out to these variety of other opportunities, dictated, of course, by local needs and the fitness of Catch curriculum and materials to the needs of those populations. Next slide. So I'll close just by highlighting the aspiration of MD Anderson, as well, I think, of the Catch Global Foundation, and that is to make evidence-based, in this case, cancer prevention, control, or health promotion more broadly, elevate that as Plan A rather than Plan B or C. And we hope to do that in every regard across the spectrum of risk factors everywhere, certainly here in Texas, but progressively across the nation and the world, and by all means, policy, education, and service being those in cancer control, as well as clinical-based, individualized prevention delivery, as I've outlined it for you. So that's our ultimate aspiration as an institution, and I think it's this mission that really attracted us to our Catch Global Foundation partners. Next slide. So I want to end by thanking the Catch Global Foundation as well as its existing partners for permitting us the honor of working with you. You can get a little bit of what we hope to bring to the table, but we have as much to learn as we have to share, and we hope to grow our relationship so that we can become more effective as partners working together. Special thanks go out particularly to Steve Kelder and Deanna Holscher for their welcome invitation to join them in this effort, as well as Duncan Van Dusen for all of his work to help bring that hope and that aspiration into reality. I think that's my last slide. Maybe there's one more. Yep, just to highlight Dr. DePino's commitment to this part of our mission and to our work with the Catch Global Foundation specifically. You can see there he says, with Catch, we're fortunate to combine our expertise with a successful, long-standing program providing practical research-based approach to child health that's already national in scope. We hope to only help you in further enhancing the effectiveness and the reach of the program looking forward. Thank you very much for your attention. I'm happy to turn it back over to Duncan and his colleagues to answer any questions that may come up.
Super. Thank you, Dr. Hawk. That was extremely interesting and informative. We do have just a couple minutes for questions, so if you have a question, please type it in, and we will get it out. Okay. First question is, do you have an estimated timeline of when you hope to have Catch available in the digital format? And that may be a question for me as much as for you, Dr. Hawk. So why don't I take first crack at it? It is an undertaking that we've already begun. We have been spending the last couple months selecting a partner for the digital rollout, and we're actually right now conducting a discovery process over the course of the next couple of months to identify exactly what features and functions our Catch users value the most and what would be most helpful to them in using the digital Catch format. So if any of those on the webinar are interested in participating in that advisory group and in that process, please email us at info@catchinfo.org, and we would be, very happy to talk to you about joining that. And Dr. Hawk, did you want to add anything?
I just agree. I think it's a huge opportunity, but it's best tailored and developed based upon the needs. And there's so much experience in the field already with the Catch program. I would say MD Anderson is a relative latecomer. This is one of these places where we'd love to hear from the folks that are out there doing the work, and then we can try to figure out how we can complement and live up to that desire.
Okay, I've got one other question if we have time, Brooks, and that is, I agree with your focus on creating measurable, lasting results. How can you say a little bit more about how you measure those lasting results in cancer prevention?
Sure. Well, I gave you a couple of examples. Largely, there's no mystery here. The Catch program, I think, was developed particularly looking at reducing cardiovascular impacts in its original form. But you do that by measuring proximate goals and your attainment of those. So in something like this, it begins with change in knowledge before or after. Something that simple can be relatively important. Then you've got to prove that the knowledge is resulting in changed behaviors. So there, typically in a cancer prevention study, we would look for the adoption of healthy behaviors or the suppression of unhealthy behaviors. So that would be things like that study with Aspire, where we're showing kids not adopting tobacco in the subsequent 18 months. That doesn't indicate what they'll do over the next 20 years, but it nevertheless is a piece of evidence suggesting that you're on the right path when you reduce that by 60-70%, as was demonstrated in that short-term study. But ultimately, we'll only know if we're living up to the success we intend 20, 30 years in. So, you know, again, I don't have a magical answer to that. I think it's through all the hard work of measuring changes in knowledge, changes in behavior in the short term, with the strong association between that knowledge and behavior with long-term outcomes, as is typically shown through large observational studies. But that's what we're attempting to do, is to take a look at the short-term changes in knowledge and behaviors, hoping for that longer-term impact.
Great, thanks again, and thanks to all our participants. I think we're out of time now, so for those questions that we didn't get a chance to answer, we will provide answers through our blog.
And I want to thank everyone again for attending, and remind you that the webinar was recorded and will be online at catchusa.org. We'll be sure to send you all the link. Everyone who registered will get that link sent straight to their inbox. And I just want to thank you again, Dr. Hawk, for an excellent talk, and we'll see everyone hopefully next month. Thanks.
Thank you. Really wonderful being with you. Bye-bye.
Thanks. Bye-bye.
Bye.